Thank you very much. Ladies and gentlemen, it's my great honor to talk about functional alignment, total arthroplasty. During the past 37 years, my alignment orally has been changed a lot. At the beginning, I used the mechanical alignment until 26 years. Now, last 2 to 3 years, changed a lot to a functional alignment. As you know, mechanical alignment is a long history and a good long-term result. We cut the bone, proximal femur and distal tibia, perpendicular to the mechanical axis. Very easy and simple. And I feel sometimes very difficult to get gap balancing, especially in flexion gap. So recently, kinematic alignment is introduced to restore patient pre-arthritic and joint surface and also ligament laxities. Some report faster recovery and better functional outcome. However, in extreme anatomic variation, it may be at risk of failure sometimes. So restricted kinematic alignment concept introduced to correcting severe deformity a little bit by adjusting component positioning into safe range of limb alignment, so-called 3 degrees. So hip and knee alignment make it within 3 degrees, and tibial cut, femur and tibial cuts are within 5 degrees varus valgus. What about functional alignment? Using restricted kinematic alignment, they are still unsatisfactory in terms of gap balance. So in that case, no more ligament release and just change of component positioning within its limit for ligament balancing. It's the philosophy of functional alignment. 61-year female patient, as you see here, he has a mechanical varus 12 degrees, LDFA is 92 degrees, MPTA is 86 degrees. So according to this preoperative measurement, I set the implant positioning, as you see, and maximal varus stress applied in the pre-extension and the non-tibial flexion. As you see here, lateral gap is 24, and the flexion gap is 27. In this typical case, flexion gap is a little bit looser than extension gap. So I wanted to adapt this kind of ligament laxity situation, proximal tibia and distal tibia cut a little bit less than preoperative measurement, 3 millimeter less. So I performed tibial cut as I planned, and then osteophyte removed at the medial side, and a little bit preliminary medial release using a 19 gauge needle puncture, pipe cross technique. I insert 12 millimeter metal block on the proximal tibial cut and the valgus varus stress, and confirm the limb alignment as you see here. Still 9 degrees mechanical varus, and the lateral side is a little bit looser. So I medial release once again, several more times pipe cross tech, and then 12 millimeter block was inserted, as you see here. Now I can bring the knee joint into 5 degrees varus. So I'm satisfied it. And then knee brought into 90-degree flexion, 20-pound distraction force applied medially, laterally. You can see here's a difference is medial, lateral. So at this time, if you want to do without any further component position change, you can do with the further medial release. It means more soft tissue injury. However, in philosophy of functional alignment, you do not do any more ligament release. Instead, component position was changed a little bit. This is 2 degrees valgus into 1 degree valgus. Then you can get the satisfactory medial and lateral extension gap. And also flexion gap, you can see this, and the external rotation is changed a little bit. You can get a good flexion gap. This is the post-op X-ray. So I did a comparison study, 100 cases of thoracic arthroplasty. Functional alignment provides better flexion gap, as you see here. Modified kinematic alignment group, only 43% has a good flexion gap. However, functional alignment has 100%. And functional alignment has a more external rotation of a femoral component. So in summary, there's many different types of alignment. Still, nobody knows which one is better. However, functional alignment is a very interesting concept to have an excellent knee balance. Thank you very much.